So the patients with HLRCC kidney cancer, they're very different than the type cancers that we see in patients with VHL or hereditary papillary renal cancer, which tend to be indolent. They can spread when they get larger than 3. They can spread and cause metastatic cancer, no question about it. But in the HLRCC patients, those cancers can spread when they're very small. And so we do not recommend doing active surveillance until the largest tumor reaches 3 centimeters. In those patients, we recommend surgical intervention now and not waiting. And we do a very different operation. We go very wide on these. These can be very infiltrative, very aggressive cancers. Now, these are one of the most, some people think the most, maybe the most aggressive type of kidney cancer, but I also think it's the one that has the biggest Achilles heel. So in studying the pathway of that Krebs cycle enzyme gene, fumarate hydratase, we have developed a therapy targeting that pathway with bevacizumab and erlotinib. And we have seen really dramatic response in our patients. We're very excited about this. We've seen in the patients with HLRCC, as well as the patients in regular papillary kidney cancer, this trial, again, being run by Dr. Ram Srinivasan in our group. Dr. Srinivasan is seeing responses of 65% before we lost all these patients. A very aggressive disease. Now we're seeing very dramatic responses, very, very prolonged disease-free progression in these patients, and we're very encouraged about this. We're working now to develop even better therapies, and we have a second line trial that we're running now, which is targeting a similar pathway. And so we're working toward the day that these patients won't have to have surgery, and we'll have therapy for 100% of those patients. But we're very encouraged about where we are right now with this therapy.